Now let's move on to Streptococcus pneumoniae. This is one of the most common infections that you'll encounter, and we're going to see that this bacteria is the #1 cause of multiple conditions, and we'll find out what they are. Important characteristics. It's a gram-positive diplococcus, meaning it's found in pairs and stains a purple-blue color on gram stain. It's also encapsulated with a polysaccharide capsule. This is the most important virulence factor of strep pneumoniae. This polysaccharide capsule prevents it from being phagocytosed and is what allows the strep pneumo to invade so diffusely throughout the body and cause so many problems. If it didn't have the polysaccharide capsule, it would not be as effective. The key thing you want to know about the polysaccharide capsule is that this polysaccharide capsule is made of polysaccharides. Remember that T cells from immunology, they respond to peptides and proteins. They can't really respond to polysaccharides. So if you want to attack a polysaccharide, the spleen is very important with opsonization, complement, and IgM from B cells. So the spleen plays a major role in fighting encapsulated bacteria and encapsulated infections, and it's because of the polysaccharide capsule found there, because a T cell response is not really that possible. You need a B cell response instead. So strep pneumo colonizes the throat and nasopharynx. So because it colonizes the nose and the throat and nasopharynx, it is able to spread from there and cause further infections. So diseases associated with Streptococcus pneumoniae are either due to aspiration, like pneumonia. Remember, if you aspirate your oral secretions or aspirate colonization in throat and nasopharynx, it can go down into the lungs and cause aspiration and a pneumonia as a result. But it's not the same as an aspiration pneumonia with anaerobes. It just means that the strep pneumoniae is aspirated into the lung, and that's how it causes an infection. In addition, strep pneumo can also cause direct invasion from the throat and nasopharynx. What are some nearby organs near the throat and nasopharynx? Right, we have the mastoids. You can get mastoiditis. You have the otitis media, the middle ear. You also have the sinusitis, so the sinuses are nearby, so you can get sinusitis, and even meningitis when it infects the meninges. So direct invasion and aspiration are the ways that strep pneumo moves around through the body and causes infections. So those are the examples that we mentioned before. There's also an Iga Protease. This is a step 1 concept, but it'll help you understand how strep pneumo causes the problems it does. It really commonly affects mucous membranes. And why does it do that? How does it affect the sinuses, the otitis, the middle ear, the lungs? How does it do all that? By Iga Protease. It destroys the IgA and mucus and prevents it from being cleared. So if you can't clear the bacteria using IgA and mucus, the strep pneumo can build up and cause problems. And that's why it causes all the problems we've been talking about. So it's easily identifiable by gram stain. Remember, it's a gram-positive diplococcus. It'll be a purplish blue color. And it's dangerous in patients with functional or anatomic asplenia, such as sickle cell. So we talked about how important the spleen is in taking care of polysaccharide infections. So this polysaccharide capsule protects the Streptococcus pneumoniae from our T cell response. So we need a B cell response, which is primarily in our spleens, to combat this infection. So if you have functional asplenia like sickle cell or an anatomic asplenia from a trauma, you will not be able to handle the polysaccharide capsule of strep pneumo, and it will cause disseminated sepsis and major infections, possibly even death. And the reason why is that you don't have B cells to allow for opsonization with IgM, IgG, and C3 to allow for destruction and clearance of the polysaccharide encapsulated Streptococcus pneumoniae. Now, another huge thing that strep pneumo is known for is the vaccines that it has against it. So there's a polysaccharide vaccine, which is called the pneumococcal polysaccharide vaccine, PPSV13. Has 23 different types of polysaccharide capsules in it. And this will induce a T cell independent response. It does not involve the T cells. Remember, it's got a polysaccharide vaccine. This has no proteins. So you can't have a T cell response, only a B cell IgM immunity. So infants younger than 2 years old don't have a good T cell independent response, so you should not give the PPSV13 to infants less than 2 years old. So what are some indications for it? This is very, very important. Between 2 and 64 years old with increased risk of pneumococcal infection or invasive disease. So you have high risk of disease and you're 2 to 64, you need to have PPSV13 being given. Alright, examples are 19 to 64 years old with active smoking or asthma. So a patient is 19 or older, smokes or has asthma, they need the PPSV13. If you have a high-risk condition older than 2 years old, some examples are diabetes mellitus, alcoholism, heart disease, not including hypertension, COPD, So anything that increases the risk, even immunocompromised, of pneumococcal infection is an indication for PPSV23. And once you hit 65, everyone gets PPSV23. Remember, all older elderly people are at high risk of pneumococcal infections, so they need to be protected. And this vaccine is a way to protect them. Next, how about the Pcv13 Prevnar? This is a conjugate vaccine. So what does that mean? The polysaccharide is conjugated to protein, and guess what you get? You get a T cell response. You have conjugated to diphtheria toxin protein, allowing for CD4 T cells to be involved, allowing for class switching, a T cell dependent response. So this IgM that's only found with PPSV23 can now become IgA and IgG because of this conjugated vaccine with a protein. So you can have IgA mucosal antibody produced that can get rid of asymptomatic carriage. Remember, colonize the throat and nasopharynx. This can get rid of it if you give PCV13. So what are some indications for this? Once again, all elderly people need this. Elderly people at a very high risk of disease, they're a little more immunocompromised than the rest of us, so they need to get some of these vaccines, especially PPSV23 and PCV13. So if both vaccines are indicated, give PCV13 first and PPSV23 afterward. All infants are given the PCV13 as a regular vaccine schedule. If they don't get it as infants, they can be given up to 5 years if they're healthy infants or 6 years of high risk. If it's after this time period, they don't get the vaccine until it's indicated later. So 19 to 64 years old patients can get PCV13 if they have any of these three conditions. Remember, we talked about asplenia. If you don't have a spleen, you don't have a good B-cell response, you can get a major sepsis. Immunocompromised is self-explanatory, and cochlear implant is also another reason for PCV13. This can be a risk factor for pneumococcal disease. And same, if you have 6 to 18 years old, if you have no prior vaccination history, so they missed everything, and they have these same three conditions, that's another indication for PCV13. So these are all need to be memorized. All right, I know this is unfortunate, and these are a lot of different criteria, but they need to be memorized because these are very high-yield topics that can be tested. Let's try a practice question then. Which of the following is the most appropriate next step in management? Most appropriate next step. That's what we're looking for. Send patient home with a follow-up appointment in 6 months. Provide patient with PCV13 vaccine in the clinic. Provide patient with PCV13 and then PPSV23. PPSV23 only. Or perform a chest x-ray on the patient. Alright, so we have a 25-year-old man presents to the outpatient physician's office for a regular scheduled appointment. Alright, he is doing well and has no current symptoms or issues. The physician gets a complete history and finds the patient takes no medications, has no allergies, and the only significant history is that he smokes and drinks alcohol. Okay, so that's the key history here, is smoking and drinking. He smokes 1 pack of cigarettes a day and drinks 2 beers a night. So he's an active smoker. I think you remember from the last slide what that means. And drinks 2 beers a night. Patient is in a pre-contemplative state, so he's not ready to quit. And physical exam is completely within normal limits. So what are we going to do here? We have a patient who's 25 years old and smokes a pack of cigarettes a day. So does he need some vaccination? So A, send patient home with a follow-up appointment in 6 months. No, he's an active smoker. So because he's an active smoker, he may need some vaccination. Okay, what does he need though? PPSV23 or PCV13? That's the question. Remember, PCV13 is given to patients who are asplenic, immunocompromised, have a cochlear implant, while PPSV23 is given to high-risk patients between 19 and 64. So we can get rid of anything with PCV13. We're not going to give that. And is a chest x-ray needed on an asymptomatic patient? Of course not. So that's why the answer will be PPSV23 only. Remember, active smokers between 19 and 64 are at an increased risk of pneumococcal disease and pneumococcal pneumonia and invasive pneumococcus, so they need a PPSV23 vaccine. So the criteria are pretty difficult, but it's good to know them because you can get a lot of questions right on the exam. Next, we're going to talk about some diseases that are caused by Streptococcus pneumoniae. First one that we all know about is community-acquired pneumonia. Number 1 cause is strep pneumoniae. Alright, since it's due to aspiration, you'll get a lobar consolidation in the lower lungs. So classic finding here. Because of the aspiration, remember it goes from the nasopharynx down to the lungs, it will have a consolidation in the lower lungs. That's where aspiration goes. And that's the reason why. When you aspirate, it goes down to the lungs because of gravity. Symptoms of community-acquired pneumonia caused by strep pneumo. You have fever, shaking, chills. These are key features of pneumonia caused by strep pneumo. Fever and shaking chills. You get a productive cough. Blood-tinged sputum is another classic finding. And pleurisy, also known as chest pain with inspiration. It's also the most common cause of post-URI pneumonia or post-influenza pneumonia. We talked about this in the Staph aureus section. So for diagnosis, best initial test, remember step 2 loves this, is chest x-ray. And sputum culture is taken to guide therapy to see what antibiotics will work. So treatment, you give IV antibiotics if they're inpatient, and the empiric therapy is ceftriaxone and azithromycin and doxycycline. The reason for this is you're going to treat for atypicals like mycoplasma, chlamydia, and you're also going to treat for the common infections for lobar pneumonia, such as Haemophilus influenza, strep pneumo, and Moraxella catarrhalis. So the empiric therapy is covering for all of these different conditions. So you give ceftriaxone plus azithromycin or doxy. If it's outpatient, you just need oral antibiotics, and just azithromycin or a fluoroquinolone, such as moxifloxacin, levofloxacin, or gemifloxacin is enough. Otitis media now. Strep pneumo, once again, most common cause. And the same causes are common with strep pneumo, are common with otitis media and pneumonia. Strep pneumo being most common, non-typal Haemophilus being number 2, and Moraxella catarrhalis being number 3 for both pneumonia and otitis media. So some risk factors for otitis media. Secondhand smoke is a major risk factor. It's also a risk factor for asthma in kids too. Very high yield thing to know there. Age as well. Young kids have a horizontal orientation of the eustachian tube. Let's see what that means. So, say the eustachian tube looks like this, and this is in children, and in adults it looks like this. Which is more likely to drain? Yes, this one, because gravity is able to pull it down. Here, everything will just stay static and not move, and as a result, you can have a higher risk of infection and bacterial buildup. So now the pathogenesis of otitis media. So it commonly happens after a viral URI. So after a URI, you get a lot of infection and damage to the nasopharynx and the structures around it, and you can get a blockage of the eustachian tube due to dead cells and due to inflammation and edema. And because of that, you can get backup of fluid and bacterial overgrowth inside of the eustachian tube. So what are some symptoms and signs? A key thing to know is that otitis media can actually have systemic signs like fever, poor feeding, and diarrhea. Remember, diarrhea is actually a pretty common childhood and systemic sign. So look for that when you're looking for a systemic disease. You can also have ear pain, pulling or rubbing the ear. That's a classic finding. And bulging tympanic membrane. So the tympanic membrane, the middle ear, is inflamed and edematous and full of pus, and it's going to bulge against the tympanic membrane. Otorrhea means drainage from the ear, so that can be caused by an infection as well. Hearing loss because the middle ear is inflamed and infected. And the major finding on physical exam is pneumatic otoscopy, where you put air against the eardrum and you have decreased or absent tympanic membrane mobility. If this is present, most likely the patient is going to have otitis media. Diagnosis is clinical, as you've seen here. And the treatment is going to be amoxicillin if there's no recent beta-lactam therapy and no history of recurrent otitis media. So amoxicillin is the treatment as long as they haven't taken amoxicillin or other things in the past, which can cause resistance in the bacteria. And if you have recurrent otitis media, amoxicillin probably will not work. So amoxicillin is given if there's no recent beta-lactam therapy and no recurrent AOM. So what are some guidelines for recurrent otitis media? If you have recurrent otitis media, we first need to define what that is. So that means that you have greater than or equal to 3 incidences of otitis media in 6 months, or greater than or equal to 4 incidences of otitis media in 12 months. And all this is written down at the bottom of the slide in the notes section when you go over these slides on your own, but these are important to know. So if you have these frequent incidences of otitis media, prophylactic antibiotics are needed, and amoxicillin is given prophylactically. But for treatment of recurrent otitis media, you're going to have to give something stronger like amoxicillin clavulanate. And say the amoxicillin prophylaxis doesn't work and they still get otitis media, that's when you need tympanostomy tubes. Those are the ear tubes that kids sometimes get from ENT surgeons. So otherwise, give amoxicillin clavulanate. Remember, if amoxicillin is contraindicated, give amoxiclav. Now, a major thing about otitis media is all the complications that can happen. You get conductive hearing loss because of damage to the middle ear, balance and motor problems due to damage to cranial nerve 8, the vestibular part, tympanic membrane perforation because of the infection and the bulging, mastoiditis because of local infection and local invasion, and meningitis for that exact same reason. Now some more diseases caused by Streptococcus pneumoniae. Meningitis. Strep pneumo is the most common cause of meningitis in children older than a month old, and also in adults. Alright, very important to know that strep pneumo is a very common cause of meningitis. So the reason why meningitis happens is that strep pneumo gets into the blood and then also can locally invade into the meninges. So from the blood it can reach the blood-brain barrier and into the meninges, or a local invasion directly into the meninges. And this can happen after a URI. Remember, URI is a big risk factor for strep pneumo diseases. So symptoms in adults, you have fever, the stiff neck, I'm sure you've heard of that, the nuchal rigidity, and altered mental status because the meninges and the brain and the spinal cord and the CSF are being affected. Symptoms in children are going to be fever or hypothermia. Remember, children don't have as strong of a hypothalamus and temperature regulation is not as mature. So you actually get hypothermia with meningitis, nuchal rigidity, poor feeding, and lethargy. So these are the neurologic findings in kids. They're very tired and don't want to do any activity, especially feed. What are some classic physical exam findings? I'm sure you've heard of the Koenig sign. The Koenig sign means that you cannot extend the knee fully during 90-degree flexion of the hip. So I want you to imagine standing up and lifting up your hip while keeping your knee straight. And then if you kick your leg out, you can make your leg go completely straight. So let me give you an example of this. So say you're standing and this is your leg, okay, and you have a leg here. So what it would look like is that this is a full extension of the leg. So when you have extension of flexion of the hip, that's 90-degree flexion of the hip, and you keep the leg like this, that means that when you have Koenig sign, you cannot move this leg upward to this position right here. So when you're standing up, the hip is upward and the leg is down. You cannot flex the leg, extend the knee fully, and that's because of pressure against the neck. So if you try and extend your leg, you'll notice that there's some pressure in your back as well. So because of that, the nuchal rigidity prevents you from able to move your leg from the flexed 90-degree position to a 180-degree full extension. Brzezinski sign. What is this? So Brzezinski sign means that if you flex the neck passively, so you flex the neck for the patient, the hips also flex involuntarily. So you have an involuntary flexion of the hips with flexion of the neck. That's another classic finding of meningitis. So for diagnosis, we have lumbar puncture with CSF analysis. Very, very important. The best way to diagnose meningitis is to look at the CSF itself. So a key thing to know is, when is a CT done before a lumbar puncture? So this is a critical thing to know because if you do a CT and a patient has increased intracranial pressure, you could predispose them to having a herniation of the brain and major long-term complications. So when do you do a CT prior? You do it if a patient has altered mental status, so you can rule out a brain lesion or some kind of increased intracranial pressure. If they have new focal deficits, which is a sign of some kind of problem in the central nervous system, new onset seizures, or papilledema. Remember, papilledema is a sign of increased intracranial pressure. So any of those indications are reasons not to do a LP first and do a CT beforehand. So on the lumbar puncture, we'll have some specific findings for bacterial pneumonia. We'll have increased white blood cell count greater than 1,000 with a neutrophilic predominance. Remember, this is a bacteria, an extracellular bacteria, so neutrophils will be the ones fighting it the strongest. A low glucose level, less than 50. Remember, both the neutrophils and the bacteria are eating up the glucose. Elevated protein due to the antibody immune response. And a positive gram stain. We'll have gram-positive diplococci showing up on the gram stain. Now meningitis continued. Empiric therapy. So we need to figure out what to do for this meningitis empirically. What we're going to do is we're going to give a third-generation cephalosporin and vancomycin. And the reason we're going to do this is that we want to cover the different causes empirically. Vancomycin is cover the strep pneumo. We could have a very virulent strep pneumo, so we want to make sure we cover it completely with vancomycin. The third-generation cephalosporin is to combat Haemophilus influenza, which is another very common cause of meningitis. Also, in adults, dexamethasone is needed in pneumococcal meningitis. If you find out that the meningitis is not caused by pneumococcus, you can discontinue the dexamethasone. But this is critically important for patients who have pneumococcal meningitis. And the reason why is that dexamethasone will decrease the inflammation in the CSF and the meninges. Meninges line the brain and spinal cord. So less inflammation you have, the less likely you'll have neurologic sequelae. So So it's very important to give dexamethasone in adults for pneumococcal meningitis. Another key thing to know is that for empiric therapy, if an adult is over 50 and presents with meningitis, you also need to give ampicillin IV in addition to the other two empiric antibiotics because of the high risk of listeria. So now we need to talk about the complications of meningitis. So a very common complication is hearing loss. Because meninges are affected and the meninges are also covering the cranial nerves, you can have hearing loss as well. You also have increased risk of seizures in the future. Now let's talk about our last disease associated with Streptococcus pneumoniae. We have acute sinusitis. So these sinuses are inflamed and congested as a result of Streptococcus pneumoniae. So what are some symptoms of this? We have a thick yellow-green discharge from the nose, nasal congestion, fever, maxillary tooth pain. Remember, the maxilla is the upper part of the mouth, mandible being the lower. Inability to smell because of the nasal congestion, headache, and facial pain and fullness. So these are some classic symptoms of acute sinusitis that you should be able to recognize. So how do you know if it's bacterial or viral? Viral, you're not going to treat with antibiotics, but bacterial, you will. So it's bacterial if it's very prolonged, more than 10 days of symptoms. If it gets better and then suddenly worsens, that means the bacteria super infected this. And also if you have severe symptoms for at least 3 days. So that means high fever, severe pain and facial pain and fullness, or a purulent nasal discharge for 3 days. So take a look at this. This is what the normal sinuses look like. Look at how open these are. But if you have chronic sinusitis, look what happens. All of these different sinuses get full of mucus. And this is a major problem here. And you get backup of fluid, backup of mucus, backup of dead cells, backup of neutrophils. And this is going to cause congestion in the face and cause the facial pain and fullness in the discharge from the nose. Diagnosis is clinical. Okay, you don't need to do any kind of imaging unless you're suspicious of major complications, such as an orbital cellulitis as a result of the sinusitis, or a CNS invasion leading to encephalitis or meningitis. Otherwise, you can just assume that it's sinusitis based on the symptoms and treat accordingly. So if it's viral, you're not going to treat it. You're just going to let it go and treat it as if it's a URI and give symptomatic therapy. So if it's mild and viral, you'll give NSAIDs, nasal irrigation with saline, or nasal steroids to help with the symptoms. But if it's severe, you need to give amoxicillin clavulanate. Especially if it fits any of these 3 criteria here, amoxicillin clavulanate is absolutely necessary. And you have prolonged symptoms, you have to give antibiotics. So if you have symptoms for a long time, more than 7 days, even if these aren't fit, you should give antibiotics for them because it probably is not viral anymore. Viral usually lasts less than 7 days. If it goes beyond, it's probably bacterial, and you can give antibiotics.